projection is an issue. It is a slide projection, you can always rotate manually and do it. Before that, we use the OHPC. Very simple. Even if you play out of the thing here, you can bring it up, back it, within a second you can project. When I was doing undergraduate, I would sit in front of that OHPC. It will be very warm. Then I will shift one paper to another paper. It's easy for the lecturer to just go without any interruptions. Yeah, like we got to the you see this, actually this particular thing we presented the presence of Keshav Das and our Dr. Vinod is a professor and head robotic and automation of PhD Institute of Technology. We presented this. So this is the thing I took over a month time where we did thoracic mastectomy, diaphragmatic repair, upper lobe thoracic mastectomy, thymoma excision for myasthenia. The myasthenia timing is the minimal access, robotic is very fast recovery because there is no big thoracotomy. The recovery from this anesthesia tracks all these things very good for the myasthenia. So you should choose this procedure even if it is going to add some extra cost, those going to deserve in a post-operative recovery. Next one. This is a nostalgia, memorize. And this one on the day of your presentation is actually supposed to be an international conclave on robotic work. And this was the thing is established for a robotic exhibit which is displaying some of the utility of robo in different areas, including aerospace and security guard, all these things. It was a good time. We get excited to see all these things. The gentleman behind this is Mr. Arjun in the front. Behind this, Dr. Krishnamurti Raman. He's a Bangalore. He's doing a lot of work on data science as well as artificial intelligence and robotics. Why we need to know all these people? There are 4 runners to just give a platform for us to take this science and the technology to a height, so that we can utilize. So we have highly linked with so many people, and the man with mask is, I think, is Dr. Keshav. At that time, actually, we are recovering from the COVID, and SAR is associated with us. During COVID, by kind of Zoom meet, we had a RICS program, Research Innovation in Cardiovascular Science Device Manufacturing, was kind of actively participated on those online programs also. Thank you, sir, for that. This is the kind of thing we should take as a message. A cardiothoracic. Now I'm going to constrain myself to our specialty, where it says wide hope, because we have heart lung, and our operation room list is much more than any other list considered in the heart and lung, and it can be converted into a minimal access from there to a robotic. Predictable outcome, if something is not good for us, you can straight away open. Instead of putting hole, you can just make all the hole into incision, and you can access to the heart, and you can conduct the same way what we do. Because in a cardiac surgery, we need to control the heart by extracorporeal circulation, cardiac bypass. That will be already on. Only the way we approach, either we approach through the midline sternotomy or a minimal thoracotomy or part of this robotic pore, that's the difference. Once you are not happy, something is going out of our control, we can always open the chest, control the heart. So that's a big advantage of this thing, and outcome is most of the time is predictable. You see the learning curve. If you talk about the learning curve, if you already operate over 10 years, 15 years, 20 years, 25 years, you handle thousands of heart, there is no big curve required to handle this instrument, because robo is going to do a lot of wonder by endurance movements. The eye-hand coordination and your ergonomics is not like our laparoscopic or thoracoscopic surgery. Once you sit on the console, you feel that you are playing with a joystick with a video game. And somebody is educated through now the new generation of people, they become graduate like you people, you will much more better than any of us, because you have already oriented to the joystick and the video game. You can make wonder in the robotic console. And the conversion is safe and it warrants. So ultimately, recently we had one meet at our direct office, how to improve the number, how to make more productivity out of that investment. All this is actually a real question we should ask ourselves. A single surgeon in a single center investing for a robotic may not be very fruitful in the initial period, because the number is the game. You need to generate a lot of numbers to get the renovation, and there are things we will have recurrent cost on robotic utility, and this all is not in our hand. The administration and the management part, we should make this balancing between the investment and the income what we generate out of the robotic procedure. So we have some idea to this. You should do a more number, then you can minimize your time. You can utilize the operation room with a short time without much of expenditure on single case. And everybody will accept. Once you go in and bring the case in 3 hours, the people will feel good. Every day you go in 8 o'clock and come back by 8 p.m., then nobody will accept. Especially the supportive staff will get really tired and they will discuss differently. Why not just walk on and do 2 hours to finish and go during the Diwali time? All these things, you can't just hold somebody for doing with robo. So that part is very important. If you want to have more acceptance, we should have more number and short time of spending on war, and team will mature and handle these difficult situations. How to improve the number? The best thing for us, we have some contact, patient referral. They won't come to you by taking a wall repair or replacement robotic or AIT solution by robotic. They come for either minimal access or conventional. They want to live, they want to have safety on their life. In a cardiac surgery, there is no big osmosis. Scar actually severe time. They won't actually bother. If you say, then we convert it, first you pray. So that kind of understanding, our people is very good. They won't come for a robotic in the first instant. You make hundreds of numbers, then they will go, they propagate, they will say, I am safe, you will be also safe, there is no big scar here. And all these things should be given by the patient as an ambassador, as a propaganda. You can't make yourself jumping that I am doing this and you please come. That nobody will come because they will actually panic about the thing. Why not the routine conventional operation rather than some machine is operating inside? The other perception, they always feel that you are not there, the robo will operate. Like robo serving in the hotel, robo serving in some other area. That is not the case. It's completely your heart, your mind, your thing is operating. The endurance is helping you to manipulate the things and make it better. So this actually assisted robotic like laparoscopic assistectomy. If you are not very keen of completing it, you just put all the arms inside, operate and just complete with robotic assisted. At least one light will be given by the robotic arm. Initially, way back, 20 years back, Yescott Hospital, A-class heart hospital in Delhi, they do robotic mammary dissection, only used for robotic. There we see single this thing, only it will do the mammary dissection. Rest of the things, the surgeon will do a conventional or a thoracic procedure. That's long back. Now robot can complete the whole operation, especially wall repair, replacement, ASC, VSC closure, but multi-vessel CABG not very comfortably completed by robotic alone. And if you try to do all this specialty, now in our hospital we do all this cardiac, neuro, pediatric, gynec, onco, all this you combine, you can make a better number, better listing, and you should put a better outcome. Affordable and attractive package you should be considered in compared with your minimal access surgery. Then people won't think kind of higher on the operating cost. If you do a CAB, valve replacement or repair by 3 lakhs rupees, if you add another 1 lakh, they won't mind. But if you add another 3 lakh, they see it's a twice of the package. That we should consider. If you do a mixed multi-specialty work, then you can minimize the overall expenditure on the OR with the robotic, disposable as well as the instrument. The hybrid robotics, if you are really evolved, you can do one through the cath lab intervention, another one through the robotic. All this is quite possible. So this is probably the finishing this thing. The future of robotic surgery, what will be? See, for us, another 10 years will be old enough. Once you reach 60, people will say that over 60, what is new advancement you are going to do? But the 50 to 60 or the 50 to 70, sometimes you make some change, you can reach the milestone what you really expect. The growth will be steady and sustainable because, as I mentioned, the initial opening, laparoscopy 3 decades back, it's different. Now, if you say different, nobody will accept. There is no mixed response to that. It's a standardization for colectomy, for laparoscopic use of ectomy. All these things quite possible, and the recovery is time tested. On multi-specialty utility, now the specialty like ENT, orthopedics, and skull-based surgery, all is into the robotics. In another 10 years, everywhere you have a robo machine because it's going to be more familiarized, and our Aishwarya is our product. Please Aishwarya, the student should see. He is our product, now he is into the robotic kind of manufacturing unit and designing all these things, what we call the research and development. She can bring a lot of affordable instruments and everywhere it can be used in the like a concept of Make in India. That's a great opportunity because you have technology skill, but an instrument, if it's a limiting factor, you can't execute it in a big number. Solid transplantation that I was discussing, our vision, our urologist was telling, there are centers in Kochi harvesting their kidney by robotic. But I'm sure that Ramalingam is already doing it very simply and a very expanded way. And I was used to assist you because we are associated for almost 2 decades on renal transplant. I just handle the artery and vein, he do the laparoscopic dissection. Now probably is doing robotic in the center. So that's quite possible. If it's going to be in a renal, next level it will ascend to other area like hepatic, segmental dissection, anastomosis, all these things is quite possible. If the number goes up, the cost will come down. You can always say that you are doing 3 cases in a day, you cut down 50,000 in every case. The management easily accept. You do 1 case in 1 month, then you can't have anything different to cut down the cost. So number is the game. It will be one of the essential establishments most of the healthcare centers. Now in Tamil Nadu, the government of Tamil Nadu established a big advanced robotic center in Omadura Hospital, Chennai. So another version will come in every district hospital, at least the teaching hospital. It will be a countable number in most of the government sector. Inseparable skill for surgeon, it will be must like what you learn laparoscopy. When I was doing my MS general surgery, there is no big opportunity to learn laparoscopy. You can only handle the light or assist the surgeon. But nowadays, the basic, most of the MS general surgeons, they don't know how to open an abdomen for a appendectomy. That's a great loss. See, the only operation we learn throughout our MS post-graduation, appendectomy, thyroidectomy, additional hernia. Rest of the thing is on the way. We collect blood, sometimes we close the wound, sometimes we re-explore and we sleep. So these 3 operations only made us to become a surgeon. The appendectomy, thyroidectomy and hernia repair. Now there is no such opportunity. You can't take a scalpel inside the abdomen in a long way. You have to only work with the proper and cannula. So that's actually a missing area of your skill learning. But it's good for scientific jumping therapy, robotic surgery. Because your eye-hand coordination is already there, you can just evolve into full-fledged robotic surgeon for a complex procedure. Now, the great opportunity, see the whole idea of today, what the rest of the kind of speaker is going to talk about is the research, innovation, robotic, automation and AI sciences. Will improve the collaboration. See, another area we can bridge once you are a robotic surgeon into the technological people like automation, AI specialists and the engineering side, and that will be a big boon for you. Throughout the world, you can just shine your skill and your knowledge to the different skills. Engineering, science and medical specialists, once they fuse, they can do wonder in manufacturing all these things and you can make it. So this is our whole idea. We established a RICS program on behalf of our Abdul Kalam sir. So Make in India vision, technological transformation of your science into devices. See, that's a big lag in India. So we purchase all these things from other countries for valve, for so many things. But the time tested valve we have, one is a TTK Chitra, is Indian made. So that's actually is a big thing. Over 3 decades we have used thousands of valve, is Indian made and it's a very, very stable structure or the device to use in a life-saving operation, the valve replacement surgery. See, we are not only advancing our skill and the procedure, we want to educate our local community. Unless they know what is robo, how it's going to really work, all these things, they won't come for procedure. We should always educate the people in a regional language. We tried this and we conducted one kind of a conference, and this was the book we launched on this particular day. Yendira Nun Tuvaravali Ninjala Arusikche, Robotic Thoracic Surgery. Ninjala Robot. Once you see this picture, all these things, they go back to the robo, Yendira. So the Rajini movie. So all these things is almost similar, you get excited. Something is like this is going to operate, all these things. And you should not mix with other movies, such as the Malayalam, the Android Pujam. Once they see this and this, they will get confused. The robot is really life-saving or safe. So this one is the book. It's going to deal all the terminology of robotics in Tamil. I really tried my best to put this content into the Tamil language without any change. There will be a cart to become fair, the robotic field. all these things. So you should read somebody's interest in Tamil and into the science, you can enjoy that conversion of the medical science term. So with this, I thought I should call the next speaker. Before that, Ramani will introduce our invited special guest, Dr. Keshav Das. Dr. Ramani, please. Thank you very much for patient hearing.